Hello everyone. This short video is going to briefly review the anatomy and biomechanics of the spine. And we're going to go starting from the top at the ilioaxial joint all the way down through the sacrum. You have accompanying lecture outline notes as well as you actually have a copy of the PowerPoint slides themselves. So you may want to gather that information prior to starting. In addition, as we go through, you probably should make some notes on if there's information or areas where you want to actually go back to the kinesiology notes or books and review, because this is going to be a very quick overview and not in depth. Just a little bit to just kind of tickle your memory cells. So let's go ahead and get started. Just a review, these are the physiological curves of the spine, and you know that when we're first born we just have one primary curve, which is a kyphosis, and then through the action of muscle activity, particularly working against the force of gravity, we do develop a lordosis in both the cervical and then eventually in the lumbar spine. And the importance of these curves is it allows the line of gravity to pass through and yet to stay as close as possible to the ML axis in particular. The other benefit of having curves, of course, is to better withstand axial forces moving through the spine. So remember, axial forces are like up and down, kind of like along this line here. So if we're jumping or just the weight of our body, with each curve we can withstand 3.3 times more force than we could if that area was straight. So since we have three primary curves and we can multiply that by 3, essentially by having normal curves in the spine we absorb about 10 times more force than we could if the spine was completely straight up and down. So we will be looking at the impact of this later in this course, particularly when we talk about posture and postural defects and problems. So here's just again a different view of the relative amount, relatively equal amounts, a little bit more kyphosis than there are lordoses available, but fairly even in the ML axis. So starting at the cervical region, we're going to start with the atlanto-occipital joint. And up on top here you can see the atlas, and it's in B here. It's got a few individual features to it. It doesn't have a body. So see here in the front it has an anterior arch, but there's no body at all. It doesn't have a spinous process either. It just has a posterior arch. It does have very large superior articular facets. They run kind of front to back, and of course sitting on those facets, if you look down here in E, are the occipital condyles. So this is a posterior view. They've cut away the back of the skull, and you can see the occipital condyles, very convex, sitting in the concave superior facets of C1. Since that articulation kind of just goes front to back, we know of course that the primary motion between the head and C1 is flexion and extension. Let's go to C2. You can see that here in C. Also has some distinctive features, most notably the dens, the presence of the dens, which is this raised up portion. Dens, of course, meaning tooth. Kind of looks like a tooth sticking up there. That dens then fits right up against the back of this anterior arch, and you can see that here where they're in D, where they're layered over one another, kind of snugs right up against there. You can see the superior facets on C2, fairly horizontally oriented, and you can see that again here where they're actually articulating together. And since there's primarily just kind of flat horizontal orientation, the motion between C1 and C2 is primarily rotation. And the head, of course, comes along for the ride on top of C1 for that rotation. We do have some ligaments, as you can see. We have a transverse ligament here that serves to hold the dens against C1, so it keeps that articulation stable. And then going from the dens up to the occiput, the occipital condyles, we have the alar ligaments. Do you remember what alar means? Right, it means wings. So the early anatomists just looked at that and thought they looked like a pair of wings reaching up. The other name for these ligaments are the check ligaments. So they check or limit rotation. So again, we see that the head in C1 move as a unit on C2, and so that ligament, that alar ligaments going from the dens of C2, they really bypass C1, go right up to the head, and that still serves as a good check of rotation of the head in C1 on C2. The rest of the cervical vertebra are very similar to one another. They all have a body. It's kind of small compared to other areas of the spine. They have, of course, articular facets, and those facets are a little bit between the frontal and the horizontal planes. So we get the best of both worlds, and we'll look at spinal motion in just a second. In addition, one unique feature I haven't mentioned yet in the cervical spine all the way through is that within the transverse process there's a hole or a foramen. So this is called the transverse foramen. And something passes through there. Right, something important that needs to get protected. Correct. It's the vertebral artery, and this is a major source of blood supply for the brain. So that runs through that little bony channel and is protected that way. So since we have facet joints that are in two different planes, that cross planes between C3 and C7, we get a lot of motion in all planes. Flexion and extension, lateral flexion, and then rotation. So this is just a side view. It's a nice view showing the orientation of the facet joints. So you can, again, spinous processes coming out. Facet joints, you see that nice 45-degree angle here. And you can see the spinal nerve roots exiting through the intervertebral foramen. It does not show us the vertebral artery going through the transverse foramen, however. Let's look at the motion then. We have a fair amount of flexion. So we have the head on C1, as we mentioned before, and then of course the rest of the cervical spine. And overall, there's certainly more flexion than extension, and that's pretty typical of what we see throughout the spine as a whole. So when we flex, the facet articulations of the superior vertebra are sliding up and forward on the superior facets of the inferior vertebra. So that's a lot of superiors and inferiors, but essentially the facets are kind of sliding up and forward. That is going to gap or open the intervertebral foramen, and it also gaps or decreases compression on the facet joint surfaces. So here's extension. So coming back, we are compressing the facet joint surfaces, and the spinous processes approximate as well, and so that is going to limit some of the motion. And in addition, we do close or decrease the size of the intervertebral foramen. We see here lateral flexion, showing the slide of the facet joints on one another, and we end up closing and compressing on the side to which we're flexing and opening on the opposite side. And then with rotation, we again have kind of a sliding going on. And because of the nature of the facet joints orientation in the cervical spine, you might remember we've talked about a coupling of motion between lateral flexion and rotation. This coupling occurs throughout the spine, but the direction of the coupling is different. So in the cervical spine, when someone rotates to the right, as this person's doing here, they also have at the arthrokinematic surface, at the surface of the bone, they have some lateral flexion that's occurring. And when they do the osteokinematic motion of lateral flexion, we also have some arthrokinematic rotation, and that all occurs in the cervical spine to the same side. These are called Fryette's laws, and I'm simplifying them just a hair for you, but enough I think for our purposes. Let's go on to the thoracic vertebra. Obviously the bodies are getting larger. We are seeing this of course in the lateral or sagittal view. We have a good view of the intervertebral foramen here, and then here you can see the facet joint. You're seeing the side of it. So since you can see the joint line, that tells you that the joint surface is kind of flat from front to back. So that puts the facet joint orientation in the frontal plane. the spinous processes are getting longer and they're much more horizontally oriented than they were in the cervical spine, which was more vertically, or these are vertically oriented. They're much more vertically oriented. They were more horizontally oriented in the cervical spine. From the back, again, you can see here especially, you can see the very flat portion of the back of the facet joint. This also shows you the lumbar spine, of course, and then now you see the joint line again. But since we're in a posterior view, what this is telling us now is that in the lumbar spine, the facet joint orientation has switched to the sagittal plane. So let's look at motion occurring in the left vertebra. You see the thoracic spine, and in the right, on B here, you see the lumbar spine. So when we talk about trunk motion, we generally are looking at a combination of thoracic and lumbar motion together. So with flexion, of course, as we mentioned with the cervical spine, the facet joints kind of slide up and forward. We see that, and so again we have a fair amount of flexion in the thoracic and lumbar spine. Opens the facet joints, opens the intervertebral foramen. We have about half as much extension as we had flexion, and similarly we get closure of the, or compression of the facet joints and relative closure of the intervertebral foramen. For lateral flexion, remember in the thoracic spine, which is shown up here in A, we would have expected a lot of lateral flexion since the facet joints are in the frontal plane, but we see here the problem. We have ribs articulating in here, and that's going to limit that motion. And then in the lumbar spine, since we're in the sagittal plane, here we have a fair amount of lateral flexion. Rotation is a different story. In the thoracic spine, we do have a fair amount of rotation, hardly in the lumbar spine, and I think you can kind of see it here if you look. Since the facet joints are oriented in the sagittal plane in the lumbar spine, when we rotate, they kind of the superior facet just kind of runs into the lower facet, and so it really allows very little rotation, maybe a degree at each level. So when we're looking at trunk rotation, you can see she's rotating quite a bit. Most of that is coming from the thoracic spine. There is coupling again. Fryet's laws say here that when we do osteokinematic rotation, there is arthrokinematic sliding of the facets in lateral flexion, and that occurs to the opposite direction. When we have lateral flexion, we have rotation at the joint surface, again in the opposite direction. So this gives rise to what we looked at with scoliosis. When someone has a scoliosis, their spine clearly is laterally flexing, and then it would also be rotating to the opposite side. So we would, if this person was actually showing a scoliosis instead of doing a voluntary lateral flexion, we would see a rib hump on this side. We'll look at that again, we'll review that again when we look at postural deviations. I'm going to move down to the lumbosacral junction. The facet joints here flip back to the frontal plane between the top of S1, or the sacral promontory, and the inferior aspect to L5, and that's to keep L5 and the rest of the lumbar spine from sliding off of the top of the sacrum. Of course, the sacrum's fused. There is an angle between L5 and S1, and that's called the lumbosacral angle. And so here's this dotted line coming out. It's in relationship to the horizontal coming straight off of here. So here's horizontal. The articulation between L5 and S1 is angled down about 30 to 40 degrees. So if we increase the lordosis, we're going to increase that lumbosacral angle. If we decrease the lordosis, we'll flatten that angle out a little bit. And then finally, I want to look at the sacroiliac joint. This is a top view, a little hard to see here, but here's the top of the sacrum again, and it shows how the sacrum fits down or is wedged in between the ilium. If we go back here, you can see this area here. This is the side of the sacrum, and this is where the ilium would fit in against the side. This articulation is just bound by a lot of really strong ligaments. And there are definitely pathologies that occur, we tend to see SI joint disruption or pathologies primarily in women. And if you look at the characteristics or the factors that decrease stability in the SI joint that are listed in your outline, you can see that those factors pertain mostly to women. So increased lateral distance of the pelvis, so a wider pelvis, a shorter pelvis top to bottom, flatter SI joint surfaces, decreased bone density. All those things can contribute to decreased stability, which would allow the ilium to move on the sacrum or the sacrum to move on the ilium and to be disrupted. And we will be looking at SI joint pathology and how to fix it in this unit. So that's it for the bone. Just a review, a very quick review, as I said, of the spine. I didn't really review the ligaments or the muscles, and that's something I'm going to want you to do on your own as well. I do want to look briefly at the intervertebral disc. As you recall, I'm sure, the intervertebral disc has two main portions to it. It's got an outer annulus fibrosus. What does annulus mean? Right, it means ring. So fibrous ring, looks pretty fibrous and it looks ring-like. And then inside we have a nucleus pulposus. And that inner center, it always kind of reminds me of that gum that came out like when I was in middle school, and it had like liquid stuff in the middle. So you chew the gum, and the gum was kind of hard on the outside, and then the jelly stuff was on the inside. So that's what this is like. And this inner pulposus is about 90% water. And unfortunately, as we age, we do lose fluid in all our tissues, including the disc. And by the time we get to 60 or later, that there isn't much water left, but we still have functioning annulus and are able to perform the functions of the disc, and I'll go through that in just a second. This disc is what we call hydrophilic. In other words, it's attracted to water, or water is attracted to it. And when we don't have a lot of compression on it, water can kind of seep back in. So times we don't have a lot of compression would be when we're recumbent or lying down, so at night. And then during the day when we're sitting and standing and we have a lot of force down on the disc, it kind of pushes or kind of seeps some of that fluid out, and so the height of the disc will diminish. So if you've ever heard that we're taller in the morning, it is actually true, just by a little bit because of the change in the fluid within the nucleus of the disc. The annulus is really important to look at, the way it's structured. It's concentric rings that are fused together, so it's not like this is one big solid chunk. It's layers that are fused, like the layer of an onion. But maybe a radial tire is a better analogy, because each layer, the collagen fibers are oriented in a different direction. And so I think we've talked enough about collagen and connective tissue. You know that would allow each layer of the disc to withstand forces from different directions. So again, these are all fused together to provide really optimal strength. Just another view, you see the subsequent layers and the different directions of the annulus. And of course, one of the major functions of the disc is to absorb force and to dissipate it, or kind of let it get absorbed or soaked up throughout the disc itself. And so by absorbing force, it diminishes its impact on the vertebra in particular. So we just see here lots of different directions, but the point of this is that the disc can really withstand force really from any direction. We know that there is a shifting of the annulus within the disc with motion. So when if we look at the middle one, if we flex forward, that's going to compress the anterior portion of the disc, which will tend to scoot the nucleus backwards. And that's like, I always want to like to talk about food, so it's like the s'more, or maybe your sub sandwich. When you go to take a bite on the front, it kind of squishes everything out the back. Similarly, when we go into extension, spinal extension, it moves that disc back toward the center or toward the front where we might want it. And then, of course, lateral bending is going to shift it to side as well. And we're going to be looking at using these mechanics, particularly when we talk about patients who have herniated discs or herniated nucleus pulposus. We see here just some typical motions, flexing and rotating, and how that does create stress on the fibers of the disc. And we'll be talking later about kind of repetitive stress and repetitive injury and how that can weaken the fibers of the disc over time.